Welcome back, everyone, from the break. We are now entering the Midwest CPAC voting session on clinical effectiveness and value. Next slide, please. Sorry, one more. So as you're deliberating and thinking about each question, please remember that the patient population here is adults with narcolepsy type 1. If you're having trouble with the voting technology, now is a good time to reach out. But if not, then we will move ahead with the first voting question. And we're beginning with our discussion of special ethical priorities. So to help inform the judgments of overall long-term value for money, we'll be answering the following questions. Next slide. The first question is, are there particular obligations to people with this condition because of disease severity and or unmet need with currently available therapies? Tammy, Emily, I'm wondering if I could ask you to maybe weigh in on, from the patient perspective, what unmet need there might still be, even with some of these existing treatments.
I'll let Emily go first. I jumped in a lot in the beginning and then I'll follow up with anything else.
No, no problem. I saw that question pop up and I was just like feeling a lot of gratitude for my peers who shared their experiences. And I hope that's well illustrated that we're doing okay, we're getting by, but we'd like to be living a little more. And so, um, yeah, a big highlight for unmet need as far as coming up short with current treatments for both cataplexy and excessive sleepiness. Matt specifically, I appreciated that he talked a little bit about his kind of day to day and, hoping to be a provider, but realistically feeling like even at optimal treatments, he feels like he's maxed out at about 25 hours a week. And I can totally relate to that. Also having young children who want to do sports and instruments, and we find ourselves, putting a cap on a lot of things in order to survive day to day. And so that unmet need, I hope, has been adequately illustrated.
Dr.
Here,
Scam,
Emily.
Dr. Ortiz. Oh, sorry, Tammy, I didn't mean to
Oh,
interrupt.
no, you're good. If you don't mind, I'll just add a little bit. We're talking about adult population here, but as you heard the stories and the what was shared earlier, those are all coming from adults who have navigated this challenge and this struggle, the disorder with what is currently available. But if we think about the generations that's coming up and the potential that they have to have a different path to go through college, to go through this young adulthood without that burden, I think that's an unmet need that we should be recognizing, even though we're talking about adults here. These children will be adults, these adolescents will be adults, and could have a very drastic difference in their future ability and not be, held back by some of the things that we heard earlier. So thank you for asking.
Dr. Scammell?
Yeah, so there was I think we've talked about this in a sort of qualitative way, but just quantitatively, Kieran Maskey did a nice paper called Voice of the Patient. I think it was published in like 2017, where it was a survey of more than 1,000 people. And I think the presumption is that most of them are on meds, and they reported their meds in that survey. And yet, of those patients taking the conventional current medications, something like 65 to 70% said they were still sleepy. Brain fog was a huge concern. Cataplexy was a concern for only about 40%. And I think that's sort of something you've heard in other ways too. I'm not saying that cataplexy doesn't matter. It does matter. It's just that persistent sleepiness and that persistent challenge with cognition is something that's present in easily more than half of the patients on current meds.
As anyone from the ICER team would like to weigh in and offer some additional comments? Although Dr. Ortiz, if you'd like to weigh in, we'd be happy to hear your perspective as well.
No, my perspective just echoes what everyone says. It's what's out there is just oftentimes not enough. And I feel like just everyone, no matter even if they're on the newest medications, they're just they're waiting. They're like, it almost feels like a lot of people's lives are just on hold, waiting for this next stage of narcolepsy treatment, this next class of narcolepsy treatment that actually hits directly to where the problem's at. And I got, including myself, I feel like I've like a lot of my life has been put on hold, and it's kind of been felt incomplete because I can't do as much as anyone else or my peers, and I feel like I've accomplished much, but I know I could have accomplished more, and I want to accomplish more. It's just I'm still being held back, and I feel like a lot of other people with narcolepsy type 1 feel the same way.
So if there's no sort of additional perspectives from the ICER team, I'm happy to open it up to questions from the CPAC or comments. How are you all thinking about this? Brad? Brad, I think you're still, there you
I'm
go.
sorry,
Good.
I got you. 6 years you think you know how to use this technology, but I think I was I guess I was thinking about this in a quantitative, looking at the quality shortfall and EV life year shortfall, and perhaps we can review that slide again that showed that, because I think that put a numeric value for those of the more quantitative persons in thinking about this.
Program team, if they could share the shortfalls, and maybe Linda can go over it again.
So I think the request is to see the slide from the presentation with the shortfalls. Is that correct, Brad?
Yeah, and I'm sorry if that was out of script. I know I put people on the spot that weren't ready for that. So
I have the values, so I guess even maybe without the slides, just a quick reminder.
That'd be
The
great. Thank
shortfalls
you.
were absolute shortfalls about 10.4 equal value life years, which is about 25% of the remaining life expectancy when each year is valued equally, regardless of health state.
Thank you, Linda. I appreciate that. And I think we've heard anecdotally, not just from Emily and Tammy joining us now, but also from the patients who joined us during the public comment about some of the challenges that they still face, even with today's current treatments. So if there's no additional comments or questions, we can proceed. The Midwest CPAC can proceed to vote on the first question.
Can I just add, and I
Yes,
guess
of
this
course.
is, I guess this is tongue in cheek, but Brad was asking about quantification, and I was just going to say I'd probably have more children if I didn't have narcolepsy, and I know plenty of friends who have delayed family planning or not had children, and so that's a lot of quantity when it comes to mouths to feed and also joy in your heart. So.
Thank you, Emily. So if we could change to the voting slide now.
I'm happy to fill for a moment while I was told we had a little bit of a hiccup with our voting software. So I appreciate everyone's patience as we are getting the slides up for that. And my computer crashed and now it won't let me turn on my video. So as I continue to just fill this space as we talk about technology and how I'm now one of those people who doesn't know how to fix problems with IT because of age, here we go.
Thank you, ICER team, for troubleshooting. So CPAC, you may go ahead and cast your votes. I believe the number we're looking for, up there it is 13. Right. So we have 6 who voted for substantial added obligations, 6 for some added obligations, and 1 for typical obligations. Thank you, team. So we can move on to the second question, which is about whether there are particular obligations to people with this condition because it disproportionately affects those from a racial or ethnic group that have not been equitably served by the healthcare system. Maybe I can ask Dr. Lin to remind us whether there is evidence that we have in that presentation that relates to this question.
Yes, thank you, Rachel. So we don't see any differences in presentation in the rates of narcolepsy by sex or by race and ethnicity. So there isn't, as far as we know, for those categories, a difference.
And I see Tim already has a question. I'm happy to ask him myself. Maybe Tim and then Tammy, please.
Yeah, I expected that response, Grace, and that's why I read the evidence as well. But I would point out that numerous times in the report it mentioned that there were insurance issues that people faced in those with lack of coverage or getting prior authorization, and it was both in the anecdotal evidence, the interviews, and all that. So from doing a lot of work on insurance over my career, I would say people who are uninsured, people on Medicaid, we heard direct evidence from one of the patient experts about bouncing around from insurance and the challenges that they faced. So I would tell you that from all the evidence on insurance that people who are people of color are more likely to be uninsured and more likely to lack access to employer-sponsored insurance. So even though the clinical evidence might not point to this, the insurance evidence would. I just sort of point that out, and I hope that that's relevant to this question. If somebody tells me it's not, I'm just going to make that comment.
Thank you, Tim. So now we'll go to Tammy, and then I might ask Grace a question about the clinical trials.
Thank you, Tim. I appreciated those comments. And I don't know if any of my colleagues, Dr. Scammell, Dr. Ortiz, or Emily have anything to add, but we definitely see an underserved population in this area. There's a lot of stigma that goes along with narcolepsy, especially in minority communities. There's delay to diagnosis, the lack of access that was mentioned. So I don't think that it's represented in the report, but definitely exists.
Thank you. Eric?
My assessment of the racial inequality or disparity issue, I would echo what people have said, but this particular question does not allow us to explore issues of discrimination related to disability, which can be public and profound for this particular group of patients, right? Hypertension, while it has a certain racial profile that goes with it, doesn't necessarily have an outward sign of disability for people who have it. And this can affect employability, right? And or job retention. So I just want to kind of make sure that we cover that as a topic, and that doesn't probably belong in the conversation with this question, but it's an important consideration in the dialogue for CEPAC today. Thanks.
Well, and Eric, when we get to question 3,
I was like, I think sorry about that.
I think that'll be relevant.
Yeah.
Right. Felicia?
Rachel answered my first point, that Eric's point would be relevant for question 3. And I just wanted to address Tim's comments. What you said about the lack of access and how it disproportionately affects people of color would be true of any condition that has access issue. But this question is specifically saying if we have practical obligations to people with this condition, because it actually disproportionately affects those from a racial and ethnic group. And we don't have evidence that in terms of the prevalence of this condition, that it affects people of different race and ethnicity differently.
Thank you
So
for
can I follow up on that, Rachel? I'm sorry.
sure.
So my concerns about insurance, should that be dropped into question 3?
More likely, I will pick it up in the round table because I think it's an important context for the policy options in front of us and how we do that in a way that is equitable. But
So
And
go
to
ahead, Tim.
Sarah's point and Felicia's point, the question is really phrased around whether the condition disproportionately affects those from a racial and ethnic group. So even though I'm tempted to ask Dr. Lin questions about the fact that the trials received a poor rating due to the absence of data on the percentage of certain minority groups in the trial, that's also not quite related to the question that's being asked here. Right. So with that, the CPAC will proceed to a vote on question 2. And 10 votes for typical obligations, 2 votes for some added obligations, and 1 for substantial added obligations. Now, our third question is related to this point that Eric has already begun to raise, which is apart from issues around disease severity, unmet need, and race or ethnicity, are there other particular obligations to people with this condition? And because this question is phrased quite expansively, hearing comments and surfacing some of these points around whether the condition is associated with a visible disability or other types of issues are, I hope helpful for the ICER team to hear as we discuss this particular issue. Tammy, Emily, are there other thoughts or comments you have about this question?
The point of it being invisible, I think many people don't disclose. I was very proud of the public commenters that shared earlier. Many people are not able to disclose, and they're working under the assumption that they're normal and everything is fine, even though we don't like to use the word normal, but they are not able to even access accommodations or other things for fear of loss of employment or not getting a job or other things that might play a role in this. So I think considering the aspect of it being an invisible disorder is really important, along with the other stigma and things that I mentioned a few moments ago.
Yes, and I just wanted to also emphasize that like seeking accommodations is more than just like embarrassment. It's like there are experiences of people in our community who don't get proper accommodations or their employment becomes in jeopardy, or they're stigmatized by peers and end up, leaving a career path or leaving a profession. And yeah, I'll let others weigh in. I just lost my train of thought. I may have one more comment.
Sure. Dr. Lin, I think you wanted to weigh in on this question, then Dr. Scammell.
Yeah, thank you, Rachel. I think the one of the other things that we heard and that plays into this is access to specialty care. So people often have a delay in diagnosis for years. We were reading up to 10 years, on average. And especially if you live in a rural area or someplace where there aren't a lot of sleep specialists, you may not get diagnosed properly and get proper treatment.
Dr. Scammell and then Stuart.
So my comment is similar to what Grace was saying, in that, the diagnosis is often made by specialists, and yet I think that for people who are from lower income backgrounds, people of color, and so forth, their access to good sleep medicine is quite limited. And so, one of my hopes with the development of of orexin agonists in general is that it's going to just get out there into the general news, and that people will be able to advocate for themselves better, recognizing they say, "Oh, that's me, that's my story," and then they'll go seeking that specialty care more aggressively.
Thank you. Stuart and then Emily.
we heard from our patient advocates about the challenge of getting medicine, not just because of pre-authorization, but because of the stigma of stimulants and scheduled drugs and the runaround that you get when you seek them out. So I think this, to me at least, reading question 3, those kinds of situations are non-ethnic, non-racial, and are probably something that we have some obligation to consider.
Emily?
Yeah, just wanted to add that aside from the illness being invisible, it's also highly misunderstood. So even sharing about it to an employer or coworkers, it's not like I have diabetes and you can kind of understand like what the needs are. It's been mischaracterized for, forever in media. And so I think there's an embarrassment, a shame, and people don't know how to respond and don't understand what your needs are when you appear so normal with something that they've heard about. And it really looks a lot different than what most people in society um, believe.
Thank you. And I will just say maybe for the ICER team, because this is our first time with this particular wording of the question, that some of the same themes we're hearing here also resonate with me across some of the other meetings we've had, particularly about rare diseases in terms of things like access to care, the length of time it takes patients to connect with specialists. And I don't believe that this question is phrased in a comparative way, but it almost, are there particular obligations sort of relative to what? And so, it's bringing up discussions that we've had as a community before.
Yeah, and I would say the way to interpret it is really just thinking about the condition. I think a lot of the things that's been shared here, the disability that is not well understood, and the issue with diagnosis, all of those may be reasons why we feel like we should pay particular attention to this condition, maybe more than we would for others.
Thank you, Felicia. So I think the CPAC can go ahead and vote on this question 3. So we have 12 who voted for some added obligations and 1 who voted for typical obligations, with no one voting for substantial added obligations.
Rachel, you move on. I'm just going to say what we'll do is we will capture the richness of that conversation so that it is clear what you all were meaning by some added obligations there, if that makes sense.
Thank you, Sarah. That's very helpful. So now we'll move on to the next set of questions about the clinical evidence. As a reminder, the population we're focused on here is adults with narcolepsy type 1. Next slide. So this question is the current evidence adequate to demonstrate that the net health benefit of oveporexton is greater than that of no pharmacological treatment? Dr. Lin, can I ask you to refresh our memories of this question?
Yes. So as a reminder, we gave this comparison of oveporexton versus no pharmacologic treatment a B+ rating. This was based on the meta-analysis of oveporexton trials where the mean difference, and this is table 4 in your evidence summary, the mean difference versus placebo for the MWT was almost 20 minutes. The mean difference for ESS was improvement of almost 10 points. And treatment response, you were five and a half times more likely to have a normal ESS on treatment. And then in terms of harms, and I will refer you to table 9 in your evidence summary, you can see that the treatment of emergent adverse effects were mostly mild to moderate, with very few serious treatment emergent adverse effects, with the most frequent ones being urinary frequency and insomnia.
Thank you. So we've already got some CPAC members interested in weighing in. Jill?
Yeah, I just had a question, with the 2 pivotal trials being unpublished, having not gone through peer review, is there any reason to question whether or not anything would likely change coming through peer review. I mean, others on this committee might have a problem that it hasn't gone through peer review, but if we vote this evidence is adequate, it sends a message that we're good with phase 2 trial, phase 3 unpublished trials, phase 2 trials that are the only ones published. So it kind of occurred to me that might not be ideal.
Dr. Lynn, I'm not sure if you wanted to answer that directly, but I see Dr. Scammell in the queue as well.
Why don't you go ahead, Dr. Scammell?
Yeah, so I was just going to say the results of the phase 3 trial are nearly identical to those of the phase 2. The magnitude of improvement in sleepiness, the reductions in cataplexy, even the prevalence of adverse events are super similar between them. And so while the phase 3 results have not yet been peer reviewed, the phase 2 are published. In fact, it was published in New England Journal, and it's so consistent, and it's very consistent with other companies in this space that are developing very similar drugs. I personally would be shocked if there's any real surprises that come up in the review of those phase 3 papers.
Mm-hmm. I will also add that there's biological plausibility here. This is NT1 is characterized by orexin deficiency. This is a drug that addresses orexin directly. So, I think that also adds to the credibility of the findings.
Thank you. Kurt?
Yeah, I was just going to say, I feel comfortable voting yes, but I also want to point out the short duration of the trials. And so obviously I look forward to more long-term published data to support this.
Thank you. I also feel very comfortable voting yes, but I do wonder about the clinical relevance of the particular framing of this question because, as we've been talking about, it is compared to no pharmacological treatment. And we did hear from some of the patient representatives that many patients are currently not on therapy, but will the barriers that currently prevent those patients from accessing current therapies also prevent them from accessing a new expensive one? So I wonder how realistic this one is as a clinical situation, but I know we're about to answer questions that are much more closely related to that as well. All right, so CEPAC members can go ahead and vote. Well, 13 votes for yes, the current evidence is adequate to demonstrate the net health benefit is greater than no pharmacologic treatment. We can move on to the next question, which is a comparative one, whether the current evidence is adequate to demonstrate that the net health benefit of oveporexton is greater than that of modafinil with venlafaxine. Dr. Lynn, can I ask you to point us to where this information can be found?
Yes. So again, our ICER evidence rating here was C++, and we based that on evidence from the network meta-analysis, which is tables 5, 6, and 7 in your evidence summary. So versus modafinil, the MWT was a 15.5-minute difference versus modafinil. The mean difference in the Epworth Sleepiness Scale was 7 points, and then the risk ratio for treatment response was 2, although that wasn't statistically significant. I will also say that because we were not able to find combination therapy trials to put in the NMA is restricted to data from modafinil, whereas this question is asking for venlafaxine. We do have some data that venlafaxine does decrease cataplexy rates. That's in table 8.
Thank you, Dr. Lynn. That's helpful. Are there additional questions from members of the CEPAC? All right, Dr. Scammell, Dr. Ortiz, is there anything you would like to add about some of the mechanisms of action here?
Well, I think you've basically flagged that we're targeting the fundamental cause of narcolepsy, the orexin deficiency, and one thing that hasn't come up is this is targeting the OX2 receptor, and we actually hope next generation drugs are going to hit both receptors and be even more effective, but still OX2 does most of the work, and the magnitude of effects that you're seeing here as Grace just shared is, well, in my mind, substantially better than current therapy.
Thank you. All right, members of the CPAC can go ahead and vote on this question. We have 8 votes for yes, the current evidence is adequate to demonstrate a net health benefit, and 5 votes for no, the current evidence is not adequate. ICER team, should we move on to the next question, or would it be helpful to pause a moment to see if people who may have voted no would like to add any additional context for their votes?
Yes, that will be helpful, Rachel.
You do not have to. Brad?
Yeah, I voted no. If you asked if the question was, do you believe that there's likely a benefit, I would have probably said yes, but without at least an indirect treatment comparison to the combination, I didn't feel like the evidence base was there to support a yes on this. Now, if I was a patient and I was given the opportunity to switch, I would probably do it. But I just don't know if the evidence base is there yet without that, at least an indirect treatment comparison.
Thank you, Brad. That's helpful. And it relates to this issue we've discussed several times of what's current standard of care, what are patients on? We know that there was a washout period in the trial, so many patients were on something else already, and then they were deliberately compared to placebo in this case, yes.
I feel that it's going to be very more and more difficult to do a study comparing the modafinil and venlafaxine to the orexin agonist, as if it gets approved, more people get on it, recruitment for people to get off of it and switch to something else that is going to be a harder sell to make. And unfortunately, I can't foresee a lot of motivation to even do a study of combination therapy with modafinil and there are an orexin agonist, so that you can have arms of just modafinil and placebo, and then modafinil plus orexin. It's getting harder and harder to justify even that kind of study based on how well the numbers look from what we have so far. But you're right. Until we do that, we can't actually be 100% sure, and it's a shame. But also at the same point, it's like these numbers look really good, and it's a kind of a weird situation that we're in with this.
Dr. Ortiz, I'm very sorry. I'm not a clinician myself. Can I try to reframe your question back to you and
Yeah.
see if you agree with my framing? So part of what you're saying is, having not done the active comparator in this study, it may be harder to recruit for such a trial in the future, because which patients will want to go off of oviparextin to participate in a trial comparing them to active treatment with versus active treatment without. Is that correct?
Correct.
Okay. Thank you. All right, so I think we can move on to the next comparative question, which is whether the current evidence is adequate to demonstrate that the net health benefit of oviparextin is greater than that of sodium oxybate. Grace, Dr. Lin, can I ask you to remind us about where this can be found in the report?
Sure. So again, our evidence rating for oviparextin versus sodium oxybate was C++. And so I'll refer you back to tables 5, 6, 7, and 8 for the outcomes from the network meta-analysis. For sodium oxybate, oviparextin had about a 15-minute increase in the MWT and about a 7, almost 8-point difference on the Epworth Sleepiness Scale. We did not have data to do treatment responder analysis for sodium oxybate, so we don't have those data to compare. Sodium oxybates do reduce cataplexy. That's in table 8. One note about the sodium oxybates is we did, as I mentioned in the presentation, we did combine all forms, but as you've heard throughout the discussion today, there are different forms with slightly different, mostly adverse effects, with the higher sodium forms perhaps contributing to hypertension and cardiovascular risk.
Thank you. And Dr. Lin, just to follow up, how, you said that this received a C++ as well, which is the same as the rating that we were given for the previous question. Were the findings comparable then, just looking at the numbers?
Yeah, I mean I think we landed on C++ for oxybates as well as for all the comparators, and it was based mostly on the certainty. I think because these are indirect comparisons, we have no greater than moderate certainty. So it's not so much a reflection of the magnitude of difference, but more of the certainty that we have about the magnitudes of difference.
Thank you. That's helpful. Do any members of the CPAC have questions for the ICER team or clinical experts on this question?
I mean, this is Eric. I mean, is our response to this question really just how much we believe in the network meta-analysis as a method? I mean, like the question isn't really about this particular drug. It's about, do you embrace this particular method as a reasonable approach to say this? I mean, I kind of thought about the last question a little differently, but then the dialogue got me thinking that I think this is just, am I a believer in NMA as a way to do this, and that the specifics of this particular case don't matter so much. I mean, I'm curious. I mean, I guess it's a question to the group.
Alicia?
Well, now that Eric phrased it as a question to the group, perhaps the CPAC members that should be addressing that question. But I would say yes. I think part of it, the current evidence we don't have a direct head-to-head trial. And so the best we can do, decision has to be made at launch, right? This drug is going to come to market. Clinical experts are going to have to make decisions. Patients are going to have to make the decisions. And so the best evidence we have at this point in time is to be able to do indirect treatment comparison. So the question is, how much do we believe what we're saying? And putting the potential uncertainty that we still have, maybe some other outcomes that perhaps we're not able to quantitatively compare, but looking at the magnitude of benefit and based on putting all of that evidence together, what decision would I make at this point in terms of this drug versus the standard of care?
Reem?
So I'll just kind of walk everybody of how I'm thinking about this, because I do believe in network meta-analyses, and I do believe that there are multiple times that we should not be spending our energy on questions that we kind of know the answer to. So to also the discussion that happened earlier, I don't know that we have equipoise at this point about this question that it will justify with single drug. I think the bigger question is with multiple medications, and that we don't have the answer to for sure. But if I'm thinking about this, and in some of the frameworks that look at the certainty, how certain we are about evidence, I'm looking at relatively well done trials, not direct evidence, but the numbers, the large effect is actually playing into my thinking to say, even if that was not true, how large it is, it's still big enough that I believe that there is a really good benefit overall. I really think that the areas where they were uncertain is about, okay, what are the long-term harms that we don't know? And we certainly need more data about it. But if we're thinking about, and honestly, the data, it's hard to answer this question, yes, against one of the competitors and not against all of the competitors, because the evidence looks pretty comparable. That's how I'm thinking about it.
Thank you, Reem. Ingva?
Yeah, I mean, so it's whether we believe in the p-value or whether we believe in the meta-analysis. So I think there's a very fundamental methodological principle that come to play here with the network meta-analysis. The way I usually look at this is to making sure when I look at the confidence intervals, whether there's how much of any biases or confounding, in this case, this is more biases, would I need to actually negate that result? And those biases would be quite substantial, which is highly unlikely. Thanks.
So Jimmy and Brad, and then I think we'll proceed to the vote.
I think for me, it's really just going with the patient voice that we have in the room here with us who gave a really fantastic testimony of what life was like before therapy and what life is like now. The report also clearly shows that there is benefit, but if you combine the two together from the data we have from the clinical trial, be it short term, which I think we is not ideal, but we have to rely on, uh, in addition to the power of the patient voice, while the medication is going to affect each patient differently. Um, but there's one patient in here that has proven substantially that this was almost transformative in her life. So I'm using her testimony as the way I make my vote.
Thank you. Brad?
Yeah, in terms of believing into network meta-analysis and here indirect treatment comparisons, I mean, the major assumption is, are the trials similar enough, or are there effect modifiers? And if there are the trials composed similarly enough along those effect modifiers? And just to raise this, I raised this before the public discussion. This was raised, and it does not appear that there are. So I'm just responding to Eric's comment, kind of in a belief in network meta-analysis. And it seems to me, at least, that it's meeting the assumptions of it.
Thank you, Brad. So with that, CPAC members, please proceed to vote on this question. So we have 10 votes for yes, the evidence is adequate to demonstrate a net health benefit, and 3 votes for no, the evidence is not adequate. Moving on to our final comparative question on the clinical evidence. Is the current evidence adequate to demonstrate that the net health benefit of oveporexton is greater than that of pitolisant? Dr. Lin, would you remind us about these results?
So again, our evidence rating was C++ for the comparison of oveporexton with pitolisant. And then the evidence comes from tables 5, 6, 7, and 8. So for mean differences for maintenance of wakefulness against oveporexton versus pitolisant, it's a difference of 18.5 minutes. In table 6, for the differences in the Epworth sleepiness scale, it's a difference of 7 points. And for risk ratio for treatment responder, that is a 2.5-fold difference. And then pitolisant does reduce cataplexy as well, and qualitatively similarly to oveporexton.
Are there any additional questions from the CPAC members? I think we've covered a lot of the broader questions that we have about this analysis in the previous question, so I think it makes sense for us to proceed to the vote on this one as well. I think we're waiting for one more. I'm not sure if someone has sent a vote in the chat.
Everyone double check to, oh, there you go.
Thank you. We have 11 for yes, the current evidence is adequate to demonstrate a net health benefit, and 2, the evidence is not adequate to demonstrate such a benefit. So now we're moving on to a set of questions about benefits beyond health. Next slide, please. So as we try to inform judgments of overall long-term value for money, we will be answering the following questions about oveporexton when compared to sodium oxybates, modafinil plus venlafaxine, pitolisant, and no pharmacological treatment. Next slide, please. So the first question is oveporexton likely to improve caregivers' quality of life and or ability to pursue their own education, work, and family life? Tammy, can I ask you to offer your perspective on this first, and then maybe Emily as well?
Sure. Do you mind putting that question back up? so I can see exactly how it was worded or rephrasing it for me. So caregivers' quality of life, it's a hard thing to quantify. Again, we're talking about adults in this situation, but certainly there's a huge caregiver burden on the pediatric population. But we still know that there are many adults that are living with narcolepsy that rely on caregivers, whether it's a spouse, a parent, a close friend, or other roommate situation for, as discussed earlier, driving, support with appointments. We hear from many people that they will bring somebody along to an appointment because they can't focus on the appointment and take away things that they need to remember. So they show up hoping that the caregiver support person will be able to communicate some of the things that they see that they're not able to articulate, take notes about what the recommendation is by the provider, filling prescriptions, going through the access issues. I think Emily might have mentioned that's a huge burden for somebody that's already sleepy, and the process can be very lengthy and involved. And for many of our community members, simply not something that they are able to add on to their day. So in many ways, even when you reach adulthood, you're still relying on somebody for additional support. And those that don't have the support are not thriving. In many instances, aren't having the proper access to care and medications because there's not somebody there to support them in that way.
Thank you, Tammy. Emily?
Yes, I'm going to say hands down, and I guess just briefly comment on like young adults who will be eligible for the treatment and are often like transitioning from independent or from dependence to independence. Like I think it's going to be huge for kids who going through high school, parents have kind of been questioning like, is college an option? Can they move away? Uh, like, what's their career and family going to look like? That's going to be like, I'm just so excited for patients 10 years from now who have access to this. And it'll be like narcolepsy is not impacting these kind of decisions. So that's huge. And then from an adult perspective, I'll just reiterate if it hasn't come through, but like this impacts the whole family. And I definitely didn't acknowledge that when my, you know, husband, fiance at the time was willing to embark on this journey of family life with narcolepsy and the number of like hobbies he's abandoned along the way because I can only pull so much weight. And that's just become our normal. So I don't think anybody's annoyed by it. But then being on the trial, like it was like time was created for us. Like because I wasn't needing a nap during the day and like the meal was prepared when everybody got home and like we could like host family in our home and I was able to manage the schedule and the decision making in a way that hasn't existed in our lives. And so we really found ourselves thinking like if this becomes an option for you, like how are we going to reframe our priorities in life, like so that we don't just like catch up on all the Netflix that we don't indulge in, but we like use our time meaningfully and purposefully because we could see that this is going to transform our available time and our potential impact on our broader community.
Thank you. Are there questions from the CPAC or does anyone from the ICER team want to weigh in specifically on this question? I think we've heard a lot from not only Tammy and Emily, but also in the public comments about this topic. So I think it makes sense that we are ready to vote on this question. So CPAC, please cast your vote. So we have 9 votes for yes, substantial improvement, and 4 votes for yes, small improvement. And now we can move on to our final question, which is if payment or cost were not an issue, would oveporexton be likely to improve access to treatment because of its method of delivery and or treatment setting? Dr. Lin, is this something I could ask you to say a few words about?
Sure, and I also invite Dr. Scammell and Dr. Ortiz. So this is this actually came up during the clinical expert call and about diagnosis. So right now, diagnosis is pretty cumbersome, right? You have to do these sleep tests, um, and since Oveprexton addresses the orexin deficiency, it's possible that it could be a diagnostic tool as well as a treatment tool, where if somebody you suspect has NT1 responds to Oveprexton, that would, confirm a diagnosis of NT1. So I think there's some, so in terms of the diagnostic burden, it may actually it may affect the diagnostic burden and also lead to more awareness and more diagnoses, more quick diagnosis more quickly.
So just a clarifying question on that. The question asks, because of its method of delivery and or treatment setting. So I totally hear what you're saying about this is the first to be treating some of the biological basis for the disease, but is that maybe separate from the question that is being phrased?
Yeah, thanks. It is a little bit separate, but it's also it plays into the the ability to diagnose if, for example, in the outpatient setting, without having to these sleep studies are done as separate, sleep clinics, and so I was thinking of it that way.
Yes. Dr. Ortiz.
And I feel that Tammy and other people have also can speak to this as well. But there's a lot of baggage with a lot of the treatments for narcolepsy. They're typically controlled substances, and a lot of times I hear that, well, I got diagnosed, and the only sleep doctor in the area doesn't want to prescribe a stimulant, doesn't want to prescribe an oxybate because it's a controlled substance, and they don't prescribe controlled substances. And usually these are the only sleep provider in the area. They're not very narcolepsy savvy. They're maybe afraid of touching these medications or managing patients with these medications. But when we have something that directly addresses the biologic cause of narcolepsy type 1, and it's not a controlled substance, it's not an addictive substance. It may be, once you get over the hurdle of the diagnostic part, the treatment part can be a lot easier because now you can expand the amount of providers that could potentially prescribe it. And maybe Dr. Scano can also put his 2 cents in on that as well, if he thinks that I'm talking out of my head here, or if he agrees with that. But that's my thought, that it might open the range of providers that may be comfortable with treating narcolepsy after the diagnosis.
So Eric, can I go to Dr. Scammell first and then come back to you,
Yeah.
or is it?
My comments are linked to Louise, so.
Mine are too. So I don't know. Louise asked my question. Done.
So we don't know yet what the scheduling is going to be. So I think we need to be a little cautious about that. We can't just assume it's going to be unscheduled, but certainly I agree with you. It seems unlikely that it's going to have much abuse potential. And so I think in that sense of like, there's a lot of docs who are very hesitant when somebody comes in and says, write me a prescription for an amphetamine. Whereas, you have another medicine like this that is more akin to prescribing insulin for somebody with diabetes. One would hope that targeted approach where you're really just trying to give back what's missing improves people's comfort and confidence in prescribing.
Thank you. Felicia?
I was also going to add a different dimension that currently for sodium oxybates, patients actually have to wake up in the middle of the night, either once or twice, to take. Again, this is one of the most effective therapies out there, but patients have to wake up in the middle of the night, and that will not be an issue here.
Thank you. Stuart?
So if you take this question literally, I think the answer is no, because it's specific to method of delivery or the treatment setting. But I agree that a lot of these issues that are being raised could be incorporated into one other phrase added to this question in the future, because I think it gets to the point of this question. So I would vote yes if we could fudge a bit on the language.
Emily?
Yes, and my question, I guess, kind of related to what Stuart brought out, is if formulation is considered Dr. Ortiz mentioned the baggage that comes with the medications, and Peluso mentioned the overnight. There's also flavor issues that people have with the nighttime oxybate treatments, and sometimes it's unreasonable based on your living situation to be sedated throughout the night, and like a daytime med that you can take as a little pill would be a more appropriate choice for some patients.
Emily, I'll appreciate. I'm gonna jump in. I think the sort of or formulation / storage, because the other thing that we heard from patients was especially college age, needing to be able to securely store the sodium oxybate that we don't expect will be an issue with oveporexin. So I'm happy to sort of have that be stipulated as implied with this question, and when we report back, we'll make sure we emphasize that. So if you all want to kind of vote with that in mind, Madam Chair, is that okay with you?
I think that makes a lot of sense, right? So we're normally thinking about, this is an infused drug, which is now in an oral form, right? And so we're changing the treatment setting, the method of delivery. This is a little bit different. So I think Emily and Stuart, your friendly amendment to formulation and then Sarah's addition of storage is very helpful.
Great.
So with that, I think we can proceed to the vote. So we have 10 votes for yes, small improvement, 2 for yes, substantial improvement, and 1 for no. So with my thanks to not just the other members of the CEPAC, but to Emily and Tammy, as well as Dr. Ortiz and Dr. Scammell, thank you all, as well as Dr. Lynn, of course, the members of the ICER team. Thank you for all of your help as we had this very thoughtful, I hope, discussion. So we're on a break for a few minutes and we will resume at 2:10 Central.
Thank you.